everyone. My name is Jill McLeigh. I appreciate you joining me this morning. I am in Dallas, Texas, where it is raining. Not usual weather for us, but actually a little bit chilly right now. I saw it looked like most of you that had responded to the chat box of where you were from thus far are in Oklahoma. I saw one Texan, fellow Texan. I do not have an Oklahoma connection at the moment, but I soon will. I was just telling Gal and Paula that my son is going to be attending the University of Tulsa in the fall. So, well, maybe, we hope, we'll see. We'll be having some connection to the University of Tulsa come fall. So we're hoping to be spending some more time in Oklahoma in the not too distant future. I also saw that we had somebody joining us from Maryland, which is actually where I moved to Texas from. So figuring out that there's a couple of degrees of separation with everybody on the call, right? So the focus of my talk today is meeting the health needs of children involved in the child welfare system through a model of integrated primary care. So I thought I would begin by giving you just a little bit of background information on what the child welfare system looks like in Texas. I know every state operates a little bit differently, and also every state is in a constant state of flux. So what I tell you now, 6 months from now, may look a little bit different, but some of the overall statistics and information about foster care in Texas. In 2019, which is the year that, most recent year for which we have data, there were almost 50,000 children that were in the Department of Family Protective Services conservatorship. And that includes children that are in permanent managing conservatorship, kinship placements, and other substitute care. On August 31st, there were 29,242 children in foster care in Texas. The reason that number looks so different, if you're not familiar with kind of looking at the statistics on foster care, just 49,000, that number is how many children were in the system over the entire year, and the 29,000 represents a one-day count. So on August 31st, because as we all know, children tend to move in and out of the system. Nationally, we have about 422,000 children that are in foster care. Getting a little bit more specific, in the area where I live and work is Region 3. Our Child Protective Services system divides Texas, which, as we all know, is a huge state, into regions. And so Region 3, where the arrow is pointing, the green area, covers Dallas, Fort Worth, and the surrounding counties, so up to Oklahoma, and then just a little bit south of Dallas and Fort Worth. About 10,000 of the children that are in foster care are in that region. Again, that's the August 31st. So it's about a third of all the children that are in foster care in the Dallas-Fort Worth region. Just giving you an overall idea of what foster care, looks like in Texas. We have, our kids spend an average of 19 months in care and have an average of 2.3 placements during their time in care. 4,297 children left foster care or were emancipated in 2019. Just giving you some of the key people in foster care, some of the terms that we use. In Texas, we have the Department of Family Protective Services, and within that, we have Child Protective Services. Within Child Protective Services, we have CPI, which is investigations. We have Family-Based Support Services, or FBSS, which is when an investigation is done, sometimes children are deemed to be able to be safe staying in their home with some added supports and services, and that's what we call FBSS. We have conservatorship. So this is who is considered the guardian of the child in care. Those people often overlap with being the medical consenter. And for our purposes, with a health focus on the foster care population, medical consent is very important, and knowing who the medical consenter is. Sometimes that can be the caseworker, it could be the foster parent, it could be the kinship caregiver, or it could be the child placing agency or the case manager for the child placing agency. And even child placing agency is a term that may vary across states, but in Texas, there are organizations called child placing agencies that are responsible for helping to recruit foster parents and for ensuring that foster parents receive the training, all the trainings they need and meet the requirements to be foster parents, whereas CPS is responsible for the children. So sometimes a case manager for the CPA, a medical consenter. We have
we have one question already. Does Texas law mandate how long a child can be in out-of-home care before the court will order a petition for adoption and TPR?
We have a goal, right? So they have a limit that they like to try to keep children. They don't want to keep children in care because the goal is a year, but as you can see, even the average is higher than a year. So they have a goal for terminating, either reunifying a child with their biological parent, or having the child adopted, or having a permanent managing conservatorship situation. And to be honest, I am blanking on what the actual timeline is. I know that it is a little bit like there is a deadline, but children tend to go in and out of care too. And so then that date restarts. So it's a little, I guess, more complicated than saying they have, 18 months to, when they're in care, and if they're not able to be reunified with 18 months, then the child is either going to be eligible for adoption, if that helps a little bit. So then we also have kinship placements, and then we have local permanency specialists, and that's primarily when children are placed out of region to help keep the child connected to family and networks in their local area, even when they're placed out of region. We have shelter placements, which the goal is for those to be as temporary as possible. Oftentimes, children that are placed in a shelter placement instead of into a home with a foster or kinship provider, often that's large sibling sets where it's hard to find a placement for all of the siblings, or children that are hard to place either because of they have a history of running away, or sometimes older children can be harder to find a placement for right away, and so they end up in a shelter placement, but those are temporary placements. Court-appointed special advocates, or CASAs, are volunteers who are appointed to be an advocate for the child and to help give a recommendation to the court on what the ultimate placement decision should be for that child. And then guardian ad litems, who the court appoints as a legal appointee to help identify the best interest of the child. So just a couple of the key terms that get used in foster care, and in the Texas setting, some of these may be the same in other states, but as you said, each state has some differences. And then I wanted to have just a brief intro to the idea of trauma, right? Trauma in foster care. I know that Haruv has already had a couple of sessions that have talked about trauma and adverse childhood experiences. So just a quick reminder that an estimated 90% of children in foster care have been exposed to trauma, with nearly half reporting exposure to 4 or more types of traumatic events. Comprehensive review of children entering foster care, and one state revealed that 1 in 4 children exhibited trauma symptoms requiring treatment, and that the idea that trauma can be compounded by the removal of the child from their families, loved ones, and communities, and by adverse experiences in foster care. And so in thinking about providing care for children in foster care, it's really important to have an awareness of trauma and to think about what the impact is on the child, the family, and the provider in providing care. So with that very quick backdrop of foster care and in Texas and why trauma is important, I'm going to show you a brief video just to give you a broad overview of our center, the Reese Jones Center for Foster Care Excellence, which is located we have clinics in Dallas and in Plano, Texas. and then we'll talk a bit more about the center and what we do.
Health home for children in foster care.
See if I can get it to rewind, sorry.
In North Texas.
Children in foster care oftentimes have experienced trauma. So we have what...
Sorry, it's starting part of the way in instead of at the beginning. Let me start it from the beginning. Let's see.
What's called adverse childhood experience.
All right. I think it's because I was in...
The Reese Jones Center for Foster Care Excellence brings together experts in pediatrics, mental health, and child welfare.
In the U.S., about 440,000 children are in foster care.
We are the only dedicated primary health home for children in foster care in North Texas.
Children in foster care oftentimes have experienced trauma. So we have what's called adverse childhood experiences, which includes things like abuse, it includes things like neglect, also other environmental challenges. So that can include things like divorce, incarceration of a relative. It can include violence towards a mother. These kinds of things are considered traumatic stressors for children, which can then impact health outcomes. 50% of kids coming into foster care have some sort of chronic health related illness. In terms of mental health related needs, we see a lot of trauma. So post-traumatic stress disorder is a pretty common diagnosis. We also see a lot of depression, anxiety. Many of the younger kids coming in have pretty significant developmental delays, which later impact their mental health functioning. Center is a trauma-informed center. We understand the impact of trauma on a person, on a family, and on a system. Our team is trained specifically to manage trauma all the way from the front desk, all the way back to the clinical providers. Integrated care in our model at the Reese Jones Center for Foster Care Excellence, we offer on-site collaborative care. So we have two providers in the room at the same time. So we have a mental health professional along with a medical professional working together to help coordinate care for our kids. So it's joint treatment planning.
So when a child comes in for their first integrated visit, they will see, depending on age, an early childhood specialist or a therapist, as well as a medical provider, and often the CPS liaison, who is our embedded liaison with the child welfare system, will also be involved in that visit. We'll see the child, do the kind of typical pediatric services, but in addition to that, the caregiver will have a chance to talk about any behavioral or mental health concerns that they have about the child, any developmental delays that they're noticing.
How is his behavior overall?
Overall, it's good. Saying no is the hardest part.
After the visit, all of us will come together and talk about, what do we feel this child needs? What is their individualized treatment plan as a whole child, addressing both, like I say, their mental and mental health and medical problems.
Well, the idea is that the more persons who surround a child in foster care, the better outcomes that we would get for these children.
What we know about integrated care is it reduces healthcare costs overall over time. We also know that it's better coordination of services.
As someone who's practiced in both a more kind of typical pediatric setting and in the integrated health model, I really can see the difference that this makes for children.
I think the biggest service that we offer is just making sure the families get connected to the supports, and whether it be in our center or providers out in the community, we make sure that those families are aware of what's out there, and we can't do that in a 15-minute visit.
So that's the introduction to our center and the services that we provide. And I have to say, it is a little bit strange watching that video now in this day and time. And I think about like all the handshaking and the fist bumping and all those things that we just can't do anymore. So you guys can hear me okay, yeah? Yeah, okay, great. Okay, so give you a little bit of an overview. Now you can see what happens at our center. I think we're very fortunate to have this wonderful space to be able to offer these services, but it wasn't always like this. The Children's Health hospital system, which serves the Dallas area. We also have a hospital and specialty center in the Plano area, for those of you who are familiar with this region. The foster care clinic has actually been around for more than 28 years. It was part of the centers that provide care for at-risk children and children who are basically considered vulnerable populations on our Dallas campus. It became a dedicated foster care clinic in the late 2000s, and then became the Reese Jones Center for Foster Care Excellence in 2014. But we actually didn't begin providing integrated services in the way that we are offering them now until late 2016. So it's still a relatively new model in terms of the way that care is provided. So whereas we had people who were dedicated to providing care to children in foster care, we didn't have quite the same system that we have now. The center is a partnership between Children's Health and the University of Texas Southwestern Medical Center. Our hospital is literally connected to the medical center. So our physicians are all UT Southwest employees, and then the rest of the staff are all staff of Children's Health. The center is located in the specialty center for Children's Health. We have 3 branches to our model. We have a clinical component, which is what you saw in the video, which provides medical, mental health, and developmental services. And then we have an academic and research branch where we provide training to students. We constantly, well, until recently, we were filled with students. Right now, we have no students in the center, but we have medical students, we have residents, we have nursing students, we have students who are studying to be nurse practitioners, public health students, all in and out of our center, and provide training in both the integrated care model, but also in providing care to children in the foster care system. We also, as I said, have a research component. We have several research projects underway in the center. And then we also have a research to policy focus. So we really try to focus our studies on things that are going to have an influence at the level of particularly state policy. And then we have a community branch where we focus on advocacy and policy. We focus on developing relationships in the community with other providers, health providers, but also providers who work with children in the child welfare system. And then we also run a consortium for our region. So along with our Dallas CASA and another CPA that's located in Fort Worth, we're the steering committee for this consortium that brings together, its goal is to bring together every organization that provides some type of care for children in the child welfare system to increase communication and break down some of the barriers that we often face in providing care. And if time permits, I'll talk a little bit more about the academic and community components, but I'm going to focus primarily on our clinical services. So in 2019, we saw about 1,900 unique patients. So if you think about the fact that there's about 10,000 kids in foster care in our region, and we're seeing 2,000, we're seeing about 20% of the children that come into foster care in our region. We serve children from the time they come into care through permanency. So we do, once a child is adopted, we do a transition visit, but we don't continue to see children once they are adopted. We continue if a child goes back home. We offer to provide care during monitor return. Most children, when they go back, if they are going back with their biological parent, they have about a 6-month monitor return. And so that's one thing we're really excited about. We've actively tried to encourage. We don't have the connection with CPS such that no one is forced to come to our clinic. It's completely optional. But we have seen an increase of biological parents coming to the center for the appointments during that 6-month transition. And so we've been really excited about that. So we will see the children during that monitored return time. Our model is based on the recommendations of the American Academy of Pediatrics, the Healthy Foster Care America guidelines. They recommended integrated care, and this is basically an attempt to actualize or to put into practice the recommendations that the AAP made. No referrals are required for children to come here for care. Typically, referrals are made by the child placing agencies or by Child Protective Services, or just word of mouth. A foster parent hears about us from another foster parent, or a kinship provider hears about us from another kinship provider. We haven't had to do a whole lot of active advertising as we are, as of this year, 2019, we pretty much reached our capacity of how many children we can see in our current, with our current space. So breaking down our services, our primary care services include providing a 3-day examination. In Texas, we have what's has been referred to as 3 and 30. So it's a requirement that all children, when they come into care, they have 3 mandatory visits that they need to receive during the first month of care, their first 30 days in care. One is an initial medical exam within the first 3 days. And then within 30 days, they need to have a mental health assessment known as the Child and Adolescent Needs and Strengths Assessment. And then they need to have a well visit. And so our primary care services include that 3-day exam. We do well child checks, and we also, because we are a primary care provider, we also do the sick visits. Our behavioral health team provides psychological and developmental assessments. They do the CANS assessment, which is the one I mentioned, that required assessment that needs to be done within the 30 days of a child coming into care. We also provide individual therapy. So we do evidence-based treatments, trauma-focused cognitive behavioral therapy, parent-child interaction therapy, cognitive behavioral therapy, and then we offer play therapy, especially for our younger kiddos. In terms of parent education, we provide triple P for primary care. We provide developmental and behavioral trainings and webinars. And with the advent of COVID-19, there have been a lot of changes, and one of those has meant that we are providing a lot more of webinars and doing some of that training for caregivers as we have fewer patients coming into the clinic. And a lot more of our services, like our TSCBT, we are offering via telehealth, and we are hoping to soon be able to offer PCIT via telehealth. We also do some group education, some group therapy, and then we do parent-child education as well. Other roles that we have within the clinic, you might have caught wind of our CPS liaisons from the video. We are very fortunate to have these positions. We have one in each of our clinics in the Dallas campus and on the Plano campus. These individuals are actually, they're employees with with DFPS, but they are embedded in our clinic. So there are many advantages to this, but a huge one is that they have access to Impact, which is the system that the CPS uses to keep track of all the children that are in their care. And so when we have a child who we know is coming in for a visit, our CPS liaison can pull from Impact background information, the trauma history for the child. So this is that they gather the trauma history, they can pull past mental health assessments and other documents that may be in the system. So they basically are able to get all that information before the child even comes in for the visit. So they have an idea of what this child has experienced, and they don't have to ask this child over and over again to retell what they experienced. They also liaise with caseworkers, so they provide that connection. They know the caseworkers, their fellow employees with the caseworkers, and can reach out and when more information is needed, or when they have concerns about what's happening with the child or with the treatment plan, whether it's being followed. And so it's been it's a great networking, a great way to strengthen our relationship with CPS. And then they also have just that inside knowledge and perspective. Both of our CPS liaisons worked as caseworkers for CPS prior to coming to work for us. So they know what the caseworkers are experiencing. They know that perspective, and they have a really good feel for how the system works from the inside. And so that's helped to open up a lot of conversations and avenues of support, and to help us to connect to other folks that are involved in the child's life. And then another position we have obviously our nurses, but we also have a nurse coordinator position. We have 2 nurse coordinators on our Dallas campus and 1 on our Plano campus, and they do some of the things that you typically see a nurse do. They triage sick calls. They help with obtaining some of the medical history. In Texas, we have what's called Health Passport, and the idea is it's an imperfect system if you've heard about it. It's based on claims data, and so you have all of the challenges that come with claims data, but at least it's some information about the child's medical history. So our nurse coordinators will help with pulling that information. So that's information that may not be an impact for our CPS workers to pull, but it is available, and our nurse coordinators help pull that. They also do a lot of advocacy for our patients with the managed care organization. In Texas, all children that are in foster care are on what's called Star Health. So it's one of the plans that our managed care organization, the Superior, runs. And so they have connections and networks within Star Health. And so they help parents, particularly with when in-home nursing is needed, or when durable medical equipment is needed. They help with ensuring that the caregivers are getting the services they need to be able to provide care to the child. They run our weekly huddles. So all our staff, our entire team meets on a weekly basis to discuss patients about which they have concerns. And our nurse coordinators are responsible for keeping track of all that information and bringing those patients to everyone's attention. And they also help caregivers. They spend a lot of time on the phone with our caregivers, helping them to identify resources where they're trying to find providers for occupational therapy, physical therapy, speech therapy, and making sure it's covered by the insurer. And then another thing they help with are primary medical need staffings, which in Texas anyways, for when children who have a life-threatening condition where they basically, it's defined as children who need equipment to survive. And when those children move placements, they have a staffing. And so our nurse coordinators really advocate to get us as the medical provider onto those staffings, and also often are the ones who participate in those staffings, which also then frees up our primary care providers to be able to be seeing patients. So the question that always gets raised is, how do we do what we do, right? Because insurance, we all know Medicaid doesn't pay for all of this. Medicaid reimburses about 15%, covers about 15% of the costs of providing care. We are a grant-funded initiative, and as the name suggests, we are funded very generously by the Reese-Jones Foundation. We had a very substantial initial grant to get our program off the ground. That was to develop the physical space. We are trauma-informed and attempt to be trauma-informed in every way possible. We're currently piloting a trauma-informed organization assessment with the National Child Traumatic Stress Network. And so it's been really helpful for us we're ever trying to improve our level of trauma-informedness. And so our grant enabled us to build out a trauma-informed space. As you saw in the video, some of the just amazing aspects of the physical space that allows us to do what we do, but also to be able to have some of those positions like the CPS liaisons and the nurse coordinators, which are grant-funded positions. But we do have a Medicaid carve-out, so we do receive reimbursement for services. We have had a lot of issues with reimbursement, as I think everybody does. Challenges with services not being covered, particularly with integrated care and having 2 providers in the room at the same time. That's been a challenge that we've been working with, and just figuring out how to do encounters, how bills go out. All of that has been a huge undertaking on our part and on the part of Children's to work with our managed care organization and HHSC to get those things sorted out. And then we also get funding from, because we do have a managed care organization, as a pay for performance model, we do get some supplemental funds to support our center-based treatment outcomes for children in care. And so, sustainability is something that we're always working toward and advocating for at the state level, and also seeking funding. We do get some funding from other private foundations, primarily within Texas, but we do have a few national grants and are increasingly seeking to expand our resources in that regard. I'm going to just talk about some of the lessons that we've learned in this model of care. We have learned that the growth curve was pretty significant. In 2017, the center had 5 employees, and by early 2019, we had 45 employees. So it was pretty rapid growth over time, and managing that, continuing to grow, but maintaining that, making sure everybody was trauma-informed, making sure that in our interdisciplinary environment, everybody is working on the same page, the different disciplines are respecting and listening to each other's and valuing each other's opinions and really the values that the center holds. So some of the things that we put into place an oversight committee to ensure accountability as we grow. So our overall center, while we have a leadership structure within our center, we also have an oversight committee that includes our vice president for research and operations for the hospital. We have our chair for psychiatry for the University of Texas Southwestern Medical Center. And we also have the chair of the Department of Developmental Pediatrics. So the 3 of them meet with our leadership team monthly. And that has been huge for us. It is huge because it shows how committed the hospital and the medical school are to our center and to the services that we are providing here. It also helps us to break down some of the barriers that we face in trying to push the envelope, as we do with a lot of our services, and they're very helpful in removing those barriers and just helping us to, because children in foster care aren't seen just at our center. Our children tend to have complex needs, tend to have, as the statistics showed, that they show up in our center too, right? That a lot of our children have chronic health issues. They have severe mental health issues, not all our children, but definitely the majority of our children. And so they're seen at other clinics at our hospital. And so making sure that other clinics are aware of some of the unique needs and even the challenges related to the electronic health record for children in foster care. So we do a lot of system-wide trainings and education. And then we also added work groups to our center structure for improved efficiency in the clinic. We want to make sure everybody in the clinic has a voice. So everyone serves on at least one work group. And then another thing that we've really learned is the importance of flexibility within our clinic. Our providers often call it the dance. Learning how to engage in a room with a patient and a caregiver at the same time, where you have an early childhood specialist or you have a psychologist, and then you have a primary care provider who asks which questions and who's leading what part of the discussion, I think was really challenging in the beginning. It's not anymore, but it was something that they had to learn, and how to learn how to work with each of the providers and their different personalities, and just the different way that they've been taught to evaluate a patient. And so really learning how to engage and respect those different viewpoints, and to then use those for treatment planning, and that joint treatment planning is huge. Some of the things that our work groups have done, just to give you an idea, we really value the feedback of the patients. We have a family advisory council also that helps give us feedback. And so some of the feedback that we've received, and we do rounding with patients, so one of the things that we heard is, our visits are long. They're not a 15-minute typical well-child visit. We go over a lot of education. They're getting kind of those 2 visits in one with the integrated visits. And again, not all of our visits are integrated, but our goal is for each of our patients to have at least one integrated visit. And at that integrated visit, it's determined whether or not their basically well-child check should continue to be integrated or not. So we developed this guide to clinic visits for families so that they know, depending on the type. It looks prettier. This is a handout. You're seeing a picture of a handout. It's give them an idea of what to expect at each of the visits so they know how long a new patient visit is going to last and what they can expect to happen at that visit, how long a well-child visit will last, how long an integrated visit will last, and what happens. And then on the other side of the handout, we have our behavioral health, psychiatry services. And so, yes, we're very fortunate to have a psychiatry in our clinic. And he rotates between the 2 sites. So he is in Dallas 3 days a week and Plano 2 days a week. And he has, the new patient visits, follow-up visits. And then for therapies and education sessions, the caregivers know how long they can expect to be in the clinic. We also have done a number of handouts based on what we see as common needs that children face. So in addition to trainings, we provide these. So something we see quite frequently is substance-exposed infants. More than half of our children under the age of 1 and about half of our children that are under the age of 2 had some type of intrauterine drug exposure. And so we see a lot of babies that are having some of the ramifications of that. And so we have a handout, but we've also have a number of workshops on treating substance-exposed infants. So all of these came out of our work groups with our staff. So it's been a great resource for our patients. So in concluding kind of the conversation about, and I know this is a lot of information to provide in a very short period of time. So I'd like to hope you have a lot of questions, things that weren't covered, but I wanted to kind of summarize why trauma-informed integrated care is so important for children in the child welfare system. And to be honest, all of us here agree that trauma-informed integrated care should be the norm. It shouldn't be that some kids get it, but I think if we're going to offer it to a particular population, that children in foster care are definitely a population that can benefit from trauma-informed integrated care. For one thing, and a huge piece is that it enhances access to services. We know that there is a shortage of mental health services, especially quality mental health services for children. And so being able to access those mental health services in the primary care setting is huge. And we also have those nurse coordinators who are very helpful, very vocal, and have those connections to help make sure our kids are getting in for other additional services they need, whether it be in a GI clinic or neurology, internally to children's, or if it's an external resource like early childhood intervention or physical therapy. And we believe that this trauma-informed integrated care improves the quality of care that the child receives. They receive more screenings, and they just have more time with the provider to help provide education to the caregiver and to the child. And then there is a lot of research to suggest that integrated care, ultimately results in lower overall healthcare costs. We do a lot of keeping children out of the ED, the emergency department or the emergency room, which is a huge focus. We do a lot of safety planning. And sometimes a child needs to go to the ER and we do send them to the ER if they need to go, but there have been a number of visits that have been avoided, and we're in the process of evaluating that now and looking at children that we've kept out of the ED and what the cost savings have been from that. Don't have those numbers for you yet, but we're working on it. And then just the overall improvement in mental and physical health that comes from that, but the access to the mental health services, but also that combined treatment planning. Our behavioral health team talks all the time about how much they've learned about things that may seem like they're a mental health condition, but then the physical health provider, the medical provider will point out that or realize that the child has a thyroid problem, and some of what they were seeing that seemed like it was a mental health problem was a physical health problem, and vice versa. where there were stomach issues that turned out to be a response to trauma or anxiety. And so it's been a huge education on both their parts and saves a lot of time for the caregiver and results in faster and better care for the child to address their real needs. But as I referenced earlier, there are a lot of barriers to providing integrated. Oh, that's strange. Okay, did you lose me on this slide or a previous slide?
No, it was this slide, but it was just a little bit longer.
Okay,
so if you just can repeat the last few sentences. Thank you.
Sure. Sorry, I don't know what happened. I mean, basically, bottom line is just pointing out the reasons why I think trauma-informed integrated care is good and how much our medical and mental health providers learn from each other, and how much they've been able to kind of streamline the process of narrowing down the cause of a problem, being able to identify quickly and communicate together about whether the source of the problem is mental or physical, and work together as a team to provide care for the child. And then moving into the barriers to integrated care, which I touched on a little bit before, and was just saying that, Medicaid, while there are national guidelines, there's a lot of variability across states. And in Texas, we've had a challenge with billing supporting the integrated care model. So having two providers in the room at the same time and being able to get reimbursed for those services has been challenging. One of our workarounds has been for our mental health providers to use health and behavior codes like 96150 and 96151. But just to give you an idea, the reimbursement rate for those codes is $16. So there are some changes that are happening nationally, where I think those rates are going up, which is hugely helpful. We also advocated with Superior for a long time to have higher reimbursement rates for evidence-based therapies. And that has come into place. We're really excited about that. It's a 10% increase. It's not a huge increase, but it's something. So now we're getting reimbursed at a higher rate for offering trauma-informed cognitive behavioral therapy and PC than we would for other therapies. So that was a little exciting, but still financially getting reimbursed for your services is a challenge and something that we continue to advocate for. And then just the billable time, how long you can bill for a screen. A lot of our screenings we get, an hour for, but for our kids, for example, the Child and Adolescent Needs and Strengths Assessment, the way that system works is you check, you have a question, and that question, depending on how the child responds, opens up another module of questions. And then depending on how they respond to that, opens up another module of questions. And so for a lot of children, it may be quite feasible to complete an assessment in an hour, but for a lot of our kids, it takes a lot longer, 90 minutes to 3 hours to complete that assessment because they're opening up every module. And so you're not getting reimbursed for the amount of time it takes to do these services. And then again, just this lack of coordination of services that address core social needs, especially for our children that are in kinship placement. And that's part of why we have the consortium and are working on that. While we have some structures in place to help with coordination of services for our kiddos, we recognize that there are a lot of kids just within our region that aren't coming to our clinic and so aren't having access to that coordination. And so we are really trying to work on developing systems that allow for better coordination and information sharing across the many systems that are involved with children that are in the child welfare system. And then we just have some limited data on integrated care. Most of the studies that look at integrated care are for adults, not pediatric integrated care, and they look for the impact of integrated care on specific conditions, like does integrated care benefit children with ADHD, or it just looks at, do we see an increase in referrals to behavioral health services if you have an integrated model? So it's not really looking at outcome data. And so that's something we're trying to contribute to the literature on that, but it also makes it a little bit challenging to advocate for reimbursement when you don't have that outcome data in the quantity and the quality that you want. And then again, just the limitations on trauma education and training opportunities for healthcare providers. Definitely trauma-informed care is more recognized, and the need for it is more recognized now than it was even just last year or the year before. And it's a big push in Texas right now to have trauma-informed systems. But there's still not enough opportunities for folks to get engaged, and that's within and outside the healthcare system. And I'm going to stop there, seeing the time, and open it up for questions.
Thank you, Jill. Thank you so much. I just thought about it, that this is such an amazing clinic, and I wish we had in Israel something like this, that you have. It's like, I told Paula, it's like Bethlehem for foster care children, you know, like our child advocacy center in Israel, but just without investigation, of course, and everything. But gathering together people that understand those kids and give them and the foster parents all the things that they need, it's just an amazing idea. So thank you for sharing this with us. Paula, Christina, who is doing the questions?
I'll do them.
Okay.
Hi, I'm Christina. I'm the graduate research assistant.
Nice to meet you.
So we have a comment in here that I wanted to read out loud for all the participants from Garrett. In Tulsa, we have the Fostering Hope Clinic through OU, which is staffed by our 3 child abuse pediatricians and 2 fellows. We're available to see any child in foster care, kinship, or guardianship, post-adoption, or bio parents who want to continue coming to our clinic, given our awareness and understanding of involvement with DHS in foster care. We have a case manager to help with developmental screening and any other issues the foster, kinship, or bio parents have. We also have local TU psychologists who do therapy sessions for children. Your center is an exciting example of goals that our team can continue to work toward.
Yes, and Garrett, I was just going to add, I was going to say this before I got off. I was going to mention the Fostering Hope Clinic because we participated last year in the, it's called the Pediatric Integrated Care Collaborative, which was sponsored by SAMHSA and Johns Hopkins University. And so I met, and your team also participated in that. There were 12 clinics that participated. And so we got to meet several folks from Fostering Hope, and we're able to connect that way. And we were actually planning to have your team come to our clinic to do a site visit, but obviously that hasn't happened because we're not doing meetings or site visits right now. But we were so excited to learn that there is a clinic doing something, you know, similar to what we're doing and so close by. So thank you for sharing your comment and for all the work you guys are doing.
Awesome. So we have a question. Do you have any referrals not from foster care placements, but from highly contested child custody cases, particularly those with abuse in the home, allegations of child alienation, high anxiety and stress? Also, does the center offer any medical or mental health services to the natural parents?
Oh, great questions. So yes, we take referrals from anywhere and everywhere. Most of our referrals come from CPAs and from CPS, but anybody, as long as the child is involved in the child welfare system, then we can see the child. So basically, if they're eligible for Star Health, then they can be seen in our clinic, and that is part of our mandate from our funder. We do, for the bio parent, we do services during monitored return. And again, that's just our mandate from our funder. It's a challenge, you know, it's because of our space and our, you know, just our size. We really can't expand any more than we already have. We're pretty much at capacity. And we want to be able to do more with biological parents. We we partner with other organizations that are, if you've heard of the 0 to 3 initiative, that is trying to do the joint efforts with caregivers and with the temporary caregivers and with the biological parents. And so we have provided the care, the health care for 0 to 3 families that are participating in that. And so in that regard, we've been able to provide some education to biological parents, but 0 to 3 hasn't taken off, or it hasn't really taken off at the scale we would like it to in Dallas. So we haven't had that many come through, but it's something we would love to do more of. And we try to do trainings with the providers who are providing care to families that are maybe in that family-based support services stage.
Awesome. Thank you, Jill. So the next question is, I'm a social worker in a pediatric OBGYN clinic. I was hired on to help with integrated services, check patient screenings, and help connect them with our mental health services. Any tips for getting providers on board? Many are not trauma trained or may not understand why my coming in alongside the provider would be helpful.
That's a great question. And I mean, like I said, it's still like being in this, being in the environment that I'm in, I forget sometimes, and you go to do a training and people are hesitant about trauma-informed care. And that is extremely, like you said, it's hard to comprehend once you've been in a trauma-informed environment and you see all that it does. I think part of it is trying to connect those providers to providers that have worked in a trauma-informed environment and can be champions for that trauma-informed. We found that the peer-to-peer model tends to work better. And so where there are providers, like the providers at our clinic or providers that do trauma-informed trainings, that are interacting with those providers, it tends to be helpful. And so even showing them, the video that I showed you is on our website. It's at childrens.com/foster care. So fairly easy about what it can look like, and some of the resources that the National Child Traumatic Stress Network has are super helpful about the value add. But I think a lot of providers recognize the social determinants of health, even if they don't use the terminology, and recognize that their patients are dealing with a lot more than whatever health issue may be being treated by that provider at that moment in time. And that you are a force multiplier is what we often call our early childhood specialists and our social workers and our nurse coordinators, in terms of being able to help meet those additional needs that are impacting the health of the patient. And so it's really about being able to provide care, we say the whole child, for the whole caregiver, for whoever your patient population is, that if we're not recognizing all the different forces that are at play that are impacting that individual's health, then we're not really going to be able to treat that patient. And the other piece is that when they do referrals, having you in that office really helps to ensure that the patient is able to follow through on those referrals, that it's, for a lot of our patients, it's not enough just to give a referral, right? I mean, it's not necessarily, you don't have the time to hold everybody's hand through that process, but to help make sure as you can, and as people reach out, to help them be able to access those services is huge. I will say the state of Texas, and I don't know what's happening. I don't know if where the person's from that asked the question. So have to look in to see if Oklahoma is in this stage too. But I think nationally we're seeing a huge push for trauma-informed care. It's been, a huge effort. The Children's Commission has a statewide collaborative for trauma-informed care, and are looking at developing guidance for all organizations that impact and that interact with the child welfare system. And so all of that, I think very soon is just going to become the culture. Not quick enough, obviously, but I do think that our culture is shifting from a recognition of adverse childhood experiences to the need for a trauma-informed environment and recognition of those adverse childhood experiences. So I think you're on the right side, and you just have to keep plugging away.
Awesome, thank you. And she put a comment that she's actually from Texas.
Oh, great. So that, yes, the state, it's a huge focus for the state. And I will excited to know our new DFPS head of DFPS, it has a social work background and has a trauma-informed care background. So I'm optimistic.
Great. So Christina, do we have any more questions or?
No, not at the moment. That was the last one.
So thank you, Jill. Thank you so much for your time and for this important information. And I took a lot from this, seriously. I hope we can make some changes also, I must say.
Please let me know how I can help. And if anybody wants to reach out
to Israel and create one of these clinics in our state also.
Yes. Yes, we would love to see that. We want to see these clinics everywhere. Absolutely.
So thank you very much. And Christina, see you. Thank you, Jill.